think to move on, what are anybody to discuss, what are the important things for community-based physicians to know about the immune-related toxicities associated with the modern, say, immunotherapies that are coming down the pike fast and heavy? Why don't you comment, please?
So I think, you're right. We're beginning to see a new set of toxicities in these patients, and many of them resemble autoimmune diseases.
Yes.
Many of them have autoinflammatory phenotype that our rheumatology colleagues have actually been more familiar with. There are certain that our dermatology colleagues have been more familiar with over the years. So I think, and a lot of endocrinopathies as well. So I think what has become very clear is that we need to actually be cognizant of that there's going to be a distinct set of adverse events that are going to occur in these patients. But then what's become increasingly apparent is that early detection of these lesions, of these adverse events, actually is essential for a good outcome. And this is particularly important perhaps in the context, perhaps Dan could comment on the adverse events that are occurring in, for example, in the context of CAR T cells. If you don't act early, you actually could have a really bad outcome.
Can you comment on that?
Yeah, so I mentioned in allogeneic transplantation, it's a long-term toxicity or medium-term as graft versus host. But these are very rapidly growing tumors, so the responses are extremely rapid. Mm-hmm. And what is happening is the immunotherapy in different ways produces very high levels of cytokines. Yes. And with these, like IL-6 or IL-2, these cytokines, at least at the early stages of the treatment of the patient, cause a clinical condition that looks exactly like a shock, but without bacteria. Hypotension, hypoxia. I'll talk about it in detail when we talk about the specifics, but patients go to the ICU in these. The second side effect that we see from these cytokines, and it's not clearly understood, is neurological side effects. There's neurotoxicity to these new cell therapies, and as I said, we'll talk about CAR T cells and blinatumomab, and these are the two main side effects that you don't see them in chemotherapy.
I think it's a very good point. I think that, we can't be scared, but I think educating not only the patient, but our colleagues and ourselves, we'd appreciate that those neurotoxicities that are seen, for example, we'll discuss in CAR T cell or blinatumomab, are not, they're transient and they're reversible. But you're going to be scared when the first time you see it, you're going to be like, what's going on? And the patients are going to be concerned. But if you educate them and tell them what might happen, I think it's going to be a lot easier. I think the only other point I would say is that in addition to that, with antibodies, typically it could be infusion toxicities. And I think that in most times we're pretty comfortable. We typically use Benadryl and Tylenol. And to really be comfortable with some of the more, say, active ADCC-inducing antibodies, steroids are often used for ofatumumab and obinutuzumab, we'll talk about in a little bit later. But I was just going to ask, with respect to the autoimmune phenomena, Ivan, what do you think, for example, you mentioned maybe a combination of these checkpoint inhibitors, and what do you feel that might be important for the private practice?
Well, I think the one thing that we haven't talked about is patient selection. And when you look at the trials, pre-existing autoimmune disease is an exclusion criterion, and as I think it should be when you're studying a drug. Yeah. But then the reality is that these drugs are going to become FDA approved, and they're going to get into the community, and we have a lot of patients that have comorbidities, that have Crohn's and lymphoma or whatever. And so, how that's ultimately going to play out, I don't think we know. I mean, as Madhav mentioned, there's endocrinopathies, there's dermatologic diseases, there's autoimmune diseases, and we know that these checkpoint inhibitors especially can augment them, the question, or elicit them. The question is what will happen to people that have pre-existing conditions, and I think this is where sort of the phase 4 drug development is going to occur as these drugs become more commonly used.
And I have to say that's a very good point, because with respect to lymphoma, one of the risk factors of actually developing lymphoma is having an autoimmune disorder. So a number of patients will come in with rheumatoid arthritis history or psoriasis or other types of problems, and it would be, I think we have a learning curve, but I would be unfortunate if we had to actually exclude all those patients, which you say there's a significant number of them. Yeah. I think we should move on.